We're going to continue with the next panel, who is entitled How to Prevent and How to Treat Cardiovascular Diseases in Patients with Cancer. My name is Inés Ponz. I work here at the Heart Failure Clinic. And we are going to start now with the next panel, which is going to be very interesting. I would like to remind you that you can ask questions at the end of the session, and also the people who are connected online, you can ask us, and we're going to translate the questions to the panelists. So.
Thank you, Inés. So it's my privilege to introduce Dr. Dimitrios Farmakis, who's one of our Real Madrid strikers, and he's going to tell us about prevention and management of heart failure. Dimitrios works in both Athens and Cyprus and has been one of the leaders in cardio-oncology as this field has developed over the last 10 years. Dimitrios, thank you.
Thank you, Alex. I'm mostly a goalkeeper, actually. Thank you for the nice introduction. I would like also to thank Teresa for inviting me every year to this very interesting meeting, one of the first very well-organized standalone cardio-oncology meetings. I have been here since 2018, with the exception of the dark years of the pandemic, of course. And it was a great pleasure working with Alex, Teresa, and Peter, and Gabriele, and Daniela, and the rest of the guys in the task force to publish this first ESC guidelines on cardio-oncology. And actually, the difficult thing about that was that we started with a blank page without any document before, an ESC document guiding us on what we need to update and not. So we started on a blank page, and now we have this comprehensive document of almost 300 recommendations covering all aspects. So without any further ado, I will start. Most of my slides have been shown previously by Alex, so I will be somehow more I will summarize somehow. I won't get into details. This is the definition of CTR-CD, cancer therapy-related cardiac dysfunction. It was developed before by a group with ICOS and other guys from Europe, and it was endorsed by the guidelines. We have two things here: the symptomatic CTR-CD, which is actually heart failure, and the asymptomatic CTR-CD, which are different definitions of a left ventricular ejection fraction decline or increase in biomarkers or drop in GLS. How frequent do we encounter CTR-CD? This comes from a very good Spanish registry, the CardioTox registry, the same name with the Congress, organized again by Teresa. It was throughout Spain through a network of cardio-oncology clinics. And what this registry showed that 1/3 of the patients who are at the beginning of chemotherapy, mild to moderate risk of cardiotoxicity, they will develop some degree of cardiac dysfunction during cancer therapy. Severe CTR-CD will be very rare, almost 2 or 3%, but when severe dysfunction is there, it is followed by a 10-fold higher risk of mortality. So it is important to monitor the patients closely, particularly those who are at increased risk, in order to catch this early, identify those who are prone to develop cardiotoxicity. What are the determinants of heart failure and cancer? I used to show this every time I'm talking about heart failure or cardiotoxicity. It is an interaction among 3 factors. Of course, cancer therapy who may be cardiotoxic, but also cancer itself that may affect the cardiovascular system, and the background of the patient in terms of cardiovascular disease, risk factors, and genetics. So every time that we come across a patient with a problem that seems to be heart failure or seems to be a cardiac problem, we should always keep in mind this very basic differential diagnosis. Is it cardiotoxicity, or maybe it is not? It may be related to cancer, like cancer progression that may mimic cardiac symptoms or heart failure symptoms. Other particular conditions like metastasis in the heart, and also non-cancer and non-cancer therapy-related causes that may also occur in a patient not directly related to the toxicity of therapy. So we should always keep in mind this. Is it cardiotoxicity or is it something else? Having said that, the causes of heart failure in patients with cancer, we have the direct effects of many anti-cancer therapies. Practically every anti-cancer therapy, with some exceptions may lead to cardiac dysfunction and heart failure, and we very well know anthracyclines, circulating agents, taxanes, anti-HER2 therapies, VEGF inhibitors, other TKIs, proteasome inhibitors, immune checkpoint inhibitors, MEK/RAF inhibitors, anti-androgens, and so on, an endless list. But these agents may lead directly to cardiac dysfunction or heart failure, but there are other forms of toxicity as well. For example, vascular toxicity, arterial hypertension, thromboembolism, valvular heart disease, and all these other forms of toxicity may actually lead indirectly to heart failure by affecting the cardiovascular system. And of course, we have the effects of cancer in terms of inflammation, cachexia in end-stage conditions, and a topic that this is very a topic of very rigorous research lately is the products that the cancer produces that may lead to heart failure, and vice versa, actually. And this is an overview, the journey of oncology patients in terms of the cardio-oncology evaluation. It starts with the diagnosis of cancer, continues throughout therapy, and continues after the completion of anti-cancer therapy with the aim to prevent primarily or secondarily heart failure or any other form of heart disease. And at the baseline, of course, we have the risk stratification that you all heard a lot about it. The risk of heart failure is based on a constellation of risk factors, demographic risk factors, cardiovascular, other cardiovascular risk factors, previous history of heart disease, and so on. And also some markers that we may come across during physical examination, ECG, biomarkers, and so on. So with clinical assessment and some targeted tests, we can have an idea of the baseline risk of cardiotoxicity, but we're not getting everything with this, let's say, strategies, because we have also the genetics that may affect the risk of a patient to get or not a CTR-CD. And this is a nice example with HER2. There are some small nucleotide polymorphisms, SNPs, that may modify the risk of getting toxicity from HER2 inhibitor. And there are other SNPs that are not actually related directly to HER2 receptor, but still affect the susceptibility of a patient to develop HER2 toxicity. And there are other that may be protective, like microRNAs that may be protective against cardiotoxicity. This is a nice example of this, an SNP that renders, that affects the HER2 receptor and renders the cardiomyocytes more dependent on the HER2 cardioprotection, so, and more, thus more susceptible to HER2 toxicity. But still, we can have a pretty good idea of what the risk of a patient to develop CTR-CD is with using the HFA and ICOS risk stratification proformas. This was published by Alex and many of us some years ago, and it was also, this document was endorsed by the guidelines. And the importance of this is that there are drug-specific proformas, 7 drug-specific proformas for different drugs, because each drug class has a different set of risk factors for cardiotoxicity. So we check the risk factors, we'll calculate the risk level as low, medium, moderate, high, or very high, and we define our strategy. And with this performance, we calculate the overall cardiovascular risk, not just heart failure or CTR-CD, but of course, practically all these drugs, all these 7 classes of drugs, can be related to heart failure or cardiac dysfunction. And this is an example of the proforma for anthracyclines. It contains a history of cardiovascular disease, biomarkers, demographics and risk factors, previous cardiotoxic and therapies, lifestyle factors, and with all this you calculate the risk and you define the strategy of follow-up and surveillance according to this general algorithm showing that low-risk patients will be followed routinely, moderate risk patients will require a more closer routine, let's say, follow-up, oncology follow-up, and maybe referral to a cardio-oncology service, and those at high or very high risk, they will require 2 things. First, cardiology refer, ideally to a cardio-oncology service, and second, maybe some protective measures for the primary prevention of cardiotoxicity. And this is an idea of how the different surveillance protocols look like in the guidelines. This is for anthracyclines. According to the level of baseline risk, it is the frequency of the different tests. This is organized according to cycles. For example, a high-risk patient should receive an echo every 2 cycles, and then at 3 and 12 months after the completion of therapy. In other surveillance protocols like this one for the HER2 therapies, trastuzumab and so on, it is organized, the surveillance protocols, it's organized based on time intervals because those therapies can last for long. So it is every 3 months, for example, an echo in a patient of high and very high risk and so on. So regarding prevention, I will focus on this right part of this figure. For all patients, we need to manage, of course, cardiovascular disease, cardiovascular risk factors, optimize the cardiovascular status of the patient at the beginning of cancer treatment. But in patients with high and very high risk, we need more. Besides the closer surveillance, we need also to discuss with an oncologist, hematologist on how to limit the use of cardiotoxic drugs and start some protective medications like ACE inhibitors, A or ARBs, beta blockers, or statins. We have also other approaches to this. This is a nice study by Daniela Cardinale showing us that troponin may guide us through our primary prevention strategy. So the patients who have an increase in troponin, they're started on an ACE inhibitor. And other studies like the CERCUR trial try to show this with the use of GLS. So we have also sensitive markers that may guide us through our prevention approaches. And then when the dysfunction develops, we should start heart failure therapy. This is one of the classical studies, again from Daniela Cardinale, showing that if you have a drop in ejection fraction in patients receiving anthracycline-based chemotherapy for breast cancer or non-Hodgkin lymphomas, then you start enalapril with carvedilol or bisoprolol, and then you get an impressive improvement in rate of injection fraction of more than 80% as long as you start this early enough. And according to this, we have different strategies, different algorithms to guide the management of CTR-CD. This is the case of anthracyclines. Alex showed this earlier. We have 2 parts here, a middle part that refers not what we cardiologists should do, but what the oncology treatment or the hematology treatment should be, what should be done with the oncology of or the hematology treatment, either discontinue permanently, interrupt temporarily, or continue according to the severity of the dysfunction. And then we have the part referring to the heart failure medication, full-blown heart failure therapy, ACE inhibitors or beta blockers with dysfunction without heart failure, and so on. And the same applies for trastuzumab. Again, what to do with trastuzumab, whether to continue, interrupt, or discontinue, and what to do with the heart failure medication according to our findings and the severity of CTR-CD. And of course, when we have heart failure, symptomatic heart failure, then we should refer to the 2021 guidelines on heart failure, and this is the central algorithm of those guidelines. I was lucky enough to be involved also in this document, and we do this as in non-cancer patients, but with some particularities, with some additional considerations according to the cancer prognosis, according to the cancer treatment requirements, whether there are alternatives, effective alternatives in cancer for cancer therapy, and of course drug-to-drug interactions that may be quite important, particularly for certain classes of agents like the arrhythmics or the newer anticoagulants. And of course, myocarditis, one of the forms that may lead of toxicities that may lead to cardiac dysfunction and heart failure. It has been discussed a lot lately for the immune checkpoint inhibitors. Of course, this is very important to be identified early enough because it carries a very high risk of mortality, almost 50% according to the first series of patients. So we need to find this early enough. That's why we need a surveillance protocol, and there is a surveillance protocol also in the guidelines. Measure in every cycle the troponin and the ECG for the first 3 or 4 cycles when the possibility to get myocarditis is higher, and then immediately when we have a sign of a signal of a potential cardiotoxicity like an arrhythmia, a QRS widening, or a block, a heart block, or even a rise in troponin, or even symptoms suggestive of myocarditis, of heart failure, we have to immediately hospitalize the patient, put him or her under ECG monitoring, start high-dose steroids, and of course stop the ICI therapy. And then the algorithm continues on based on how the patient responds to this initial approach. But it's not only myocarditis. We have to keep in mind that ICI that are used more and more frequently are followed by other complications from the cardiovascular system, like arrhythmias, pericarditis, vascular complications, vasculitis, and so on, and also indirect cardiovascular toxicities because of the inflammation that they may cause in other organs. And of course, tachytuba that may also be related to cancer therapy. And again, we should interrupt the culprit drug and manage the patient accordingly. Special conditions like cardiac amyloidosis, cardiac masses, carcinoid heart disease may mimic heart failure symptoms, and we have to keep this in mind as well. After cancer therapy, we had a discussion before on how we can decide whether to stop or continue the heart failure therapy. I'm not going in details. We had a discussion before according to different findings like baseline risk assessment, the response of the therapy of the patient to the therapy, and so on. And then we have the long-term follow-up after the completion of cancer therapy. This is very important. Actually, women with breast cancer 10 years after the diagnosis of cancer have a greater risk to die of heart disease than of cancer, and also the same applies to the survivors of pediatric cancer who get a 10-fold mortality, higher mortality with an 8-fold higher cardiac mortality 2 decades after the completion of the cancer therapy. So we need long-term survivorship programs, and we can base the intensity of the follow-up according to the risk stratification, and this table is for adults, for asymptomatic adult cancer survivors, and this is for asymptomatic adults who are survivors of childhood or adolescent cancer. According to the level of risk calculated with these tables, we can decide our follow-up strategy and the intensity of it. we need cardio-oncology clinics, because this is from London, from Alex's group, showing that when we do this approach, the cardiovascular approach to the cancer patient within the context of a structured service, this is done very, very effectively and actually renders the patient able to receive the best available cancer therapy, which is actually the very, very important task of cardio-oncology, among others, and of course, the importance of training on cardio-oncology and initiatives like this Congress, or the postgraduate course that Teresa has developed in Spain. They're very, very important initiatives for the training on cardio-oncology. And I will end with this, the slide that I started with. We nowadays care a lot about this relationship as well, of how heart failure actually may promote or facilitate cancer development. And I will stop here and say that there may be this reciprocal association between cancer and heart failure. Thank you.
Thank you, Dimitrios. What we'll do is have the three talks, and then we'll have all the questions at the end. So next we have another member of the Real Madrid team. He can tell us which position he plays in, Peter van der Meer. And Peter's from Groningen in Netherlands and is going to talk to us about the prevention and management of ischemic heart disease in cancer patients. Thank you, Peter.
Thank you. It's a real pleasure to be here in Madrid, second time again, and it's always a big pleasure. Well, you get me there. What position? I would say perhaps the number 10. I don't know. Prevention and management of ischemic heart disease. Some disclosures. And I think it has already been alluded before. There are a lot of shared risk factors between cancer and cardiovascular disease. Not only heart failure, but also coronary artery disease. For example, in the next slide, I will show a bit more about how high is the risk of modifiable risk factors. So on the left, we look at modifiable risk factors: obesity, diabetes, hypertension, hyperlipidemia. And on the right side, how specific anti-cancer treatments may lead to coronary artery disease: radiation, chemotherapy, checkpoint inhibitors, anti-VEGF. This is a nice meta-analysis with millions of patient data in here, and it shows the modifiable risk factors for cardiovascular disease. So, for example, very well known, of course, with the risk of smoking leads to a 9-fold higher risk for development of cancer, but also, of course, for the development of cardiovascular disease. And that's true for diet, physical activity, hypertension, diabetes, obesity, alcohol. Not everybody wants to hear that, of course, but also alcohol is a clear risk factor for both diseases. And I think the WHO now estimates that at least 30% of the cancer cases are attributable to modifiable risk factors: air pollution, smoking, obesity, etc. Very specifically, what we mention in the guidelines of specific oncological therapies that predispose to acute coronary syndromes. I won't go into detail, but I think here the radiation therapy, really the long-term effects. Later I will talk also about the acute effects and the long-term effects, checkpoint inhibitors. I think the 5-FU treatments are very well known for vasospasm, of course, but also coronary thrombosis leading to myocardial infarction. And I will show you a case with a patient who recently presented in our hospital. So we talk about early and late cardiotoxicity. Baseline characteristics here, genetic susceptibility, pre-existing risk factors, factors associated with an increased risk for the treatment-induced cardiotoxicity. Well, we talked extensively already on for every agent, and I think that's really on the guidance of Alex and Teresa, that it's very nicely shown with all the different agents what to do and when. And before the guidelines were present, I think it was not very clear. Everybody did something, and now at least we have a guideline, and as you also say, Alex, it's 75% is class C. But it's at least you sit with a big group, you look at the meta-analysis, you get expert opinion, and then you come to an advice to guide clinicians all over the world how to deal with it. So what about the acute effects on the coronaries? This is a 72-year-old male who recently came to our hospital, and he was diagnosed with non-Hodgkin lymphoma. And because he was rushed to our hospital and he was treated for his lymphoma in a different hospital, he could only tell us that he was treated for non-Hodgkin lymphoma, but had no idea what he was using. I think we can learn a lot in the Netherlands from other countries how you can easily access patient data, but in the Netherlands that's currently non-existing yet because of privacy. So we didn't know what this man was using, although we knew that he was in an active treatment with chemotherapy for his disease. He had chest pain for 1 hour. He was dizzy. He almost fainted. And it was that reason why he called the ambulance, and he was very pale. So because of the dizziness, he called an ambulance, not necessarily for the pain of the chest pain. Well, for the non-cardiologists, I think the cardiologists here, they are, whoa. The non-cardiologists are probably also saying, like, this looks different than what I normally see. Well, that's very true. So you see clearly elevation in the inferior leads, lateral leads. You see, a lot of depression in the right precordial leads. This is an inferopostural lateral myocardial infarction. And you get very worried when you see this extra beat just on top of the T wave. So we were like, whoa, this is the kind of ECG the ambulance sends us if they want to announce that a patient with a STEMI is coming, and if we agree with it. Well, we certainly agreed with it, that it would be a very good idea to come as soon as possible to our hospital, also because of the junctional escape rhythm the patient was experiencing. But before rushing him straight to the cath lab, as we would normally do, we were thinking he's currently being treated for his non-Hodgkin lymphoma, so we would like to see a first blood count. We can get that in 10 minutes to get an idea about what's his hemoglobin levels, what are his platelets. And here you can see hemoglobin levels, 9 grams per deciliter, so yes, he was pale. And the platelets were low, but not extremely low. So that left us to send the patient straight to the cath lab. And as you can see here, it's a radial approach. The right coronary artery is seen here, and there's a clear stop here in the RCA, in line. What would you expect with the AV block we were seeing, and also with the elevation in the infrapostural lateral leads. PCI was done with stenting, and here you can see the results. And actually his, I don't show the echo, but his echo we did later that day showed an ejection fraction of 45 to 50%. So very quick, he was helped to the cath lab. So and we were lucky here because the platelets were not very, very low, although there was thrombocytopenia, but not extremely low. How should we deal with the platelets? And I think in the guidelines we make clearly some recommendations. So coronary angiogram, your platelets should be above 20,000. And if not, and there's really an important reason to go for a catheterization, platelets should be transfused. For PCI and CABG, it's relatively different. It's different because you need antiplatelets to treat afterwards, and CABG, of course, the whole surgery. So it's expert opinion, and there is not really data that the platelets should not be below 30,000 for PCI and not below 50,000 for CABG. But again, level of evidence C, expert opinion. Aspirin can be used as long as the platelets are above 10,000, and below 30,000 do not use clopidogrel. And if you send patients to the cath lab, think about other ways. At least in the Netherlands, almost all hospitals are using radial access. I think it's probably everywhere. I don't know if there are some hospitals which are still using femoral access. Radial access is really preferred in patients with low platelets, and perhaps use lower heparin doses in the cath lab because of these low platelets. So what do the guidelines say? Well, this has been shown before. So what can we say? On the right here, again, the platelets, thrombocytopenia, aspirin do not use below 10,000, class 3 recommendation, so it should not be done. So it's 30,000 for clopidogrel and 50,000 for the more potent prasugrel and ticagrelor. And it could be that you could use the ticagrelor and prasugrel if the patients have a low chance of bleeding and an excessive thrombotic risk. So for a patient who just presented with a STEMI and had been treated with a stent. So what should we do with the invasive strategy? Well, I think patients presenting with a STEMI or a high-risk non-ST elevated myocardial infarction, of course you need to assess what is their risk. If they have a very poor prognosis, only have the prognosis for several months, you need to rethink. But overall, I think patients presenting, like the patient presenting here with his large infraposterolateral infarction, I think you would always send, even if he or she has a very poor life expectancy, send him to the cath lab, because it will be very difficult to treat these patients if you do not revascularize. They will get arrhythmias, they will get VT, VF, well, you know, so I think overall, go to the cath lab with high-risk STEMI patients. It is different, of course, if it's going to be a low-risk non-STEMI patient and there is a very high risk of bleeding and the troponin rise is relatively mild. I think in these cases it is well acceptable to discuss together with the patient and go for a non-invasive strategy. If we think that the cancer therapy is involved in the coronary syndrome we're seeing, like temporary interruption may be needed, and it will be a multidisciplinary team decision when to start again. And I think not only for the cardio-oncology, there are a lot of trials and discussion about how long should you give DAPT after stenting, and it may be, and I think and that's why we did not really focus on it in the guidelines, is that the acute coronary syndrome guidelines, they are very clear on how you can actually use shorter duration of dual antiplatelet. So I think taking into account if you have a very high risk bleeding patient, then you can use the ACS guidelines and use shorter duration of your DAPT, but at least a month. So what about the long-term cardiac effects? And we heard already a lot about it, mostly focused at heart failure. So we did a study a couple of years ago where we were interested in breast cancer patients who had been treated after at least 5 years after treatment, when they are being sent home to the GP, and we were interested how are these patients actually doing? What's their risk for cardiovascular disease, the risk for heart failure, but also specifically what is their risk for acute coronary syndromes, etc. So what we did is we included 350 patients with a median of almost 10 years after their primary diagnosis of breast cancer, and we divided them into a group of patients with chemotherapy and a group of patients with radiotherapy, and we matched them. And I think that's the stronger point of this study done with the GPs in our region, is that we also included women from the same GP with the same age who did not have the breast cancer or another cancer diagnosis. So we could really match them also social and geographically wise. Well, the majority of the patients in the chemotherapy group, almost 80% got anthracyclines. I think it's quite known that already 7% of the patients get trastuzumab, hormonal treatment in two-thirds, and radiotherapy, well, 100% in this group and 70% in that group. So when we look at the risk factors, you can already see that patients with cancer have already a higher risk. For example, hypertension in the patient with cancer is higher than in the patient in the control. So if you match these patients on age, then the patients who do develop cancer have a higher baseline risk. So what happened after these 10 years after diagnosis when we followed them? We did in all patients, we did an echo, and it's a little bit your talk, of course, Dimitrios, so I won't talk about the heart failure, but just one sentence. So there was an odds ratio of 2.4 that they had an ejection fraction below 54%. So yes, and there's a more than twofold higher risk of these patients developing, to some extent, cardiac dysfunction. And there's, of course, also bias, because the patients who developed in the earlier 10 years heart failure, they would have been excluded because they have been hospitalized already, or they died. And what about newly diagnosed cardiovascular disease? As you can see here, ischemic cardiovascular disease was also twofold higher in the patients treated with anthracyclines and radiotherapy. So it's not only heart failure. I think sometimes they think, oh, it's only heart failure and cardiac dysfunction. It is also coronary artery disease with high risks. One last point, you saw this slide already. We focused with the immune checkpoint inhibitors on myocarditis. I think that's the most feared one, and the myocarditis leading to the arrhythmias and sometimes Takotsubo, as Dimitrios showed. But also vascular diseases. So chronic coronary artery disease is more prevalent in the patients treated with checkpoint inhibitors. And given the great results these drugs give and the massive amount of trials which we will see and how many patients are going to use it, this will get a problem if you talk years after their initial treatment, that these patients are at a higher risk for coronary artery disease. So dear Mr. and Mrs. Chairman, to conclude, cancer and coronary artery disease share many risk factors. In addition, the cancer treatment, besides the risk factors, the cancer treatment induces or accelerates coronary syndromes. In STEMI patients, an invasive strategy is applicable for almost all patients. I think it would be wise to know the platelets before you rush to the cath lab if you have time, and if it's possible. And a low-risk non-STEMI or very high bleeding risk, you may consider a conservative approach. And the long-term risk for cardiovascular disease are considerable, not only cardiac dysfunction, focusing on heart failure, but also ischemic heart disease. I thank you very much for your attention.
So thank you, Peter. Very nice presentation. I have the pleasure to introduce you Dr. Raúl Moreno. He's the Chief of Interventional Cardiology here at the Hospital La Paz, and he's going to talk about the structural heart interventions in patients with cancer.
Thank you, Inés. And I would like to thank Teresa for this very kind invitation, and also to congratulate her for her dedication and leadership in the field of oncology, nationally and internationally. Most of the procedures we are doing in the cath lab every day are percutaneous coronary interventions that are performed to treat coronary disease. The non-coronary procedures, the so-called structural procedures, are those that are performed to treat other diseases different from coronary disease. Some of them are performed to treat valvular diseases. That is the case, for example, of transcatheter aortic valve implantation and also mitral clip. And all other procedures are performed to treat other diseases or other situations. And that is the case, for example, of percutaneous closure of left atrial appendage. The question is why non-coronary interventions are present here in CardioTox. And the main reason is that theoretically, when performing or to perform a structural procedure, we require a life expectancy longer than 12 months. That is the theory, but in the practice, in a given patient with cancer, it is difficult to predict life expectancy. And because of that, to take the decision of performing or not performing a structural intervention in a patient with cancer, it is needed to do it into a multidisciplinary team with cardiologists, oncologists, hematologists, etc. Patients with cancer have some peculiarities. Some of them are related with the indication. Generally, a percutaneous procedure is preferred over classical surgery, but the most difficult decision usually is related when we are thinking about ruling out a procedure because we consider that it is not valid for the patient. Other important peculiarities are related with the cardiac involvement of cancer, because these peculiarities not only may influence on the clinical presentation of the disease we want to treat, but also they may influence on the results of the procedure. Other peculiarities are related with the classical higher risk of cancer patients related with bleedings, thrombotic complications, and infections after surgery and interventions. And finally, in patients undergoing structural procedures, we frequently prescribe long-term antiplatelet therapy to prevent thrombotic complications associated with the device. And we all know that patients with cancer have a higher risk of bleeding complications associated with this treatment. This figure, I think, it may be applicable not only to Spain, but I think most of the countries. That is the most frequently performed structural procedure is transcatheter aortic valve implantation, the TAVI, and because of that, the TAVI will be the main focus of this presentation. The question is that there are some considerations to remember in patients with aortic stenosis. One of them is that severe aortic stenosis, symptomatic severe aortic stenosis, have a very poor clinical outcome when left on medical treatment, when left untreated. For example, in this figure, you can see how in this series, the 5-year survival of aortic stenosis was only 3%. That was lower than many patients with cancer. And the other consideration is that aortic stenosis and cancer is a very frequent association. On the one hand, many patients undergoing or with a severe aortic stenosis have also a history of cancer, but on the other hand, patients with cancer sometimes have asymptomatic severe valve diseases. And the question is, should patients with aortic stenosis be treated if they also have cancer? And here in this slide, you can see how at long term, patients with cancer have a lower survival rate in comparison with patients without cancer when are treated with TAVI. What that means is that we have to be more restrictive in patients with cancer. We have to be more restrictive, and also we have to remember that early death after TAVI is usually rated with cardiac conditions, but more than 30 days after TAVI, most of the deaths are non-cardiac. And in this series, 12% of non-cardiac deaths after TAVI were rated with cancer. However, we cannot forget also that cancer patients are also benefited by the treatment of aortic stenosis. For example, in this series, we have almost 200 patients with cancer and aortic stenosis. Some of them were treated, others were not treated, and you can observe how patients that were not treated had a significantly lower survival rate in comparison with patients that were treated either surgical intervention or TAVI. And also, we cannot forget that the benefits of TAVI over surgery are also applicable to cancer. The benefits of TAVI are mainly a significant reduction of some complications. For example, there is a 70% reduction in the risk of severe bleeding, acute kidney disease, new-onset atrial fibrillation, and these benefits are also applicable to patients with TAVI. In this series, with more than 2,500 patients with cancer, that were treated with aortic stenosis, that were treated with surgery or with TAVI, we can observe how the patients that were treated with TAVI had a significantly lower rate of some complications such as venous thromboembolism, pulmonary complications, or acute kidney injury. The situation today is that many patients undergoing TAVI have a history of cancer, and this proportion is increasing from 15% years ago, and now in the last years, nearly 20% of them. And which type of cancer does have these patients? It depends on the study. In this study, for example, the most frequent cancer in patients undergoing TAVI was leukemia or lymphoma, followed by prostatic cancer or lung cancer, but in this other series was totally different. The main type of cancer was breast cancer, followed by gastrointestinal cancer and prostatic cancer. And how are these patients that are undergoing TAVI among patients, how are these patients with cancer? Usually in this series you can see more than 60,000 patients undergoing TAVI. Those patients with a history of cancer had a similar age, but they had less frequency of coronary risk factors, less frequency of atrial fibrillation, but had a higher frequency of cardiomyopathy and heart failure. And which results can we offer to patients with cancer and TAVI? Here we have to clearly differentiate what happens at short term and what happens at long term. At short term, the risk of periprocedural complications is similar in patients with cancer and without cancer. For example, in this study at 30 days, death, myocardial infarction, stroke, etc., did not significantly differ in patients with and without cancer. The problem appears at long term, because at long term, among patients undergoing TAVI, those that have a history of cancer have a higher mortality rate at long term. You can see that here in this figure. But the problem is not cardiac mortality. The problem is non-cardiac mortality. In this study, cardiac mortality was similar at long term in patients with and without cancer. So that means that we have to individualize. For example, it is obviously not the same a patient with a previous cancer and the patient with active cancer. For example, in this study, patients with previous cancer had a similar mortality rate at long term in comparison with patients without cancer, but patients with active cancer had a significantly higher mortality rate at long term. In this other series, we can observe something similar, that is, patients with active cancer had a significantly lower survival rate at long term in comparison with patients with stable or no cancer, and patients with stable cancer had a similar survival rate at long term. And obviously, among patients with active cancer, it's not the same a patient with metastasis and without metastasis. We have also some data about that. In this study, patients with active cancer with metastasis had a significantly lower mortality rate, but those without metastasis had a similar mortality in comparison with patients without cancer. And also it's important, obviously, the stage of the cancer. Patients at stage 3 or 4 have a significantly lower survival rate. In this study, we can see how this survival was similar in patients with stage 1 or 2 in comparison with patients with cancer. So in a very simplistic way, we could say that the probability of correct indication of TAVI differs in patients without cancer, with a stable cancer, etc. There are other interesting questions in patients undergoing TAVI related with cancer. One of them is that, as you know, in patients undergoing TAVI, we usually perform a CT scan to measure aortic annulus and other data. And sometimes in these patients, we may find some masses at the CT scan that are incidental masses, and some of these masses finally are malignant masses. In this study, 2.5% of patients undergoing TAVI had a malignant mass. This is also an interesting field to research. There are some data here. You can see the survival rate. There were no differences, but obviously here, there is a selection bias. Other interesting question is that we have talked about what happens with patients that have a symptomatic aortic stenosis that have also cancer, but there are some patients that have a cancer that need to be treated, and these patients may have asymptomatic severe aortic stenosis, and sometimes we are required to treat this aortic stenosis because to allow the patients to receive the treatment, mainly surgery. There are also many cases, many evidence, or many patients that have undergone TAVI to allow the patient to receive the treatment, but in these patients, sometimes an option when there is an active cancer with an uncertain prognosis, an option may be to perform a balloon valvuloplasty as a bridge to TAVI, especially in those patients that require urgent non-cardiac surgery. Well, there are other procedures. For example, one of them is mitral clip. That is obviously an important procedure, but not so frequent as TAVI. And we have to remember that many patients with mitral regurgitation have previously diagnosed cancer, and also that some patients with cancer have also mitral regurgitation that sometimes may be even related with the treatment of cancer. And we have to remember the benefit of mitral clip. The mitral clip has a benefit in comparison with medical treatment alone in patients in whom there is a contraindication of surgery. And we have some data about the results of mitral clip in patients with cancer. For example, in this study with 165 patients undergoing mitral clip, some of them, 11% of them, had previous cancer, and these patients had a similar echocardiographic data, but higher surgical risk and more comorbidities. In this study, there is a finding that is not has not found in other studies, that was a less device success, but this has not been found in other studies. For example, in this other study with more than 400 patients, patients with cancer, that accounted 11% of the patients, had a similar echocardiographic data and similar procedural characteristics as results. So I think that as it occurs with TAVI, the results of the short-term results of MitraClip are similar in patients with and without cancer. In this other study with more than 22,000 patients undergoing MitraClip, some of them had cancer, and these patients had a similar mortality rate, acute kidney injury, stroke, or microcardial infarction. The problem, again, as it occurs with TAVI, occurs at long-term follow-up. At long-term follow-up in this study, for example, we can find a significantly lower mortality rate, both not only overall death, so there was an increased risk of death, but also in cardiovascular death. Here, in this case, was rated the increased risk of cardiovascular death was rated with heart failure that was more frequently present in patients with cancer. This is other study, and we can also see that patients with cancer had a significantly higher mortality rate at long term. Of course, here it is very important to take in consideration every patient individually. Obviously, it is not the same as it occurs with TAVI, a patient with active cancer than a patient with cancer. Obviously, patients with current cancer have a worse prognosis after MitraClip. And so it is important, again, to individualize. And finally, the third procedure I am going to comment is left atrial appendage closure, because I think that it is a procedure that may be a good option for many patients with cancer. Atrial fibrillation is very frequent in patients with cancer, and the problem is that many patients with cancer have even contraindications for anticoagulation, and because of that, in some series, more than 50% even of patients with cancer are not receiving anticoagulation. And in these patients, left atrial appendage closure is a very useful alternative. We have to remember that left atrial appendage closure even not only reduce the risk of bleeding, but even in this combined analysis of these two randomized trials, improved survival. We have data about left atrial appendage closure in patients with cancer, and as it occurs with our procedures, I could say that the periprocedural risk is similar in patients with and without cancer, except for one event that in this study was more frequent in patients with cancer. In this study, patients with cancer had an increased risk of periprocedural stroke or transient ischemic attack. That means that maybe the anticoagulation should be more exquisite in patients with cancer. I think that we can conclude 3 points that among patients referred to non-cardiac procedures, those that have cancer had an increased risk of complications, but the main problem is long-term mortality. And the second conclusion is that patients with cancer should not be excluded, because these patients are also benefited from this type of treatments. And finally, that patient selection is crucial. So long-term mortality, but not exclude these patients, and because of that, select the patients. Thank you.
Thank you very much. Are there any questions from the audience, also at home?
Do we have a microphone? Because we do have people online, so if you put your hand up, we'll get a microphone to you. Can we ask for short questions, and from the panel, short answers in the interest of time?
Yes, no. Perhaps. No.
Yes, thank you. Good morning. My name is Eduardo from Gregorio Marañón here in Madrid. I would like to ask all the panel, and especially Dr. Farmakis, about the strategies of prevention of cardiotoxicity and the treatment for cardioprotection, specifically about the indication of dexrazoxane and the use of pharmacological formulas of anthracycline less toxic for the heart. are they combined? When do we use them? And who are the aim of this cardioprotection further than the IECA and the AERC and the beta blocker treatment? Thank you very much.
This requires a long answer, actually. Very nice question. Overall, if I want to say just a general comment, because this is actually depends on each individual case, but in general, when we have a baseline risk stratification and we have a patient of high or very high risk, then we will do anything we can first to reduce the risk of cardiotoxicity without, however, compromising the effectiveness of anti-cancer therapy as much as we can. So first, we have to collaborate with the oncologist and hematologist. Second, we should optimize what we can easily optimize, like cardiovascular risk factors, cardiovascular disease, and so on. And then, whether if we have done all this, we can start some, or there are no other reasons to prescribe a cardiovascular acting drug, then the recommendations, the guidelines say that we can start a RAS inhibitor and a beta blocker and a statin if the patient is high or very high risk, and he or she has no other indications for cardioactive medication. This is a field where we do not have a lot of evidence, actually. We do not have evidence of how the more recent drugs are performing, like the ARNIs or the SGLT2 inhibitors. There are, of course, trials underway, but that's why in the recommendation, the guidelines, we restricted ourselves not to be very inclusive, and we just recommended the classical neurohormonal inhibitors and statins in patients who has no other indications for cardioactive medications.
Some other questions? So I have a very short question to Peter. Guidelines recommend temporary interruption of cancer therapy in patients with acute coronary syndrome. Could you specify a time frame where you think it's more or less?
That is very difficult to say. Depends on the risk of the cancer. So for example, so if you talk about, for example, the Herceptin, if the ejection fraction goes below 40%, you would skip one cycle, do another echo, and see whether it improves again. So it's really a patient by patient. You need to consider that. So that's really a multidisciplinary team with the oncologist. But perhaps you also can add something, Alex.
I think one point is education, particularly, I would say, for interventional cardiology. You talked about the STEMI case. So lots of STEMI cases come in where people don't connect the fact that the cancer drug may be the reason, and particularly if it's 3-monthly ADT injection therapy for prostate cancer. So it's, yes, get the PCI done and revascularization, but then just make sure on the CCU you take a good history. What is the cancer therapy you're on? And then think, is there a potential, rather than just keeping on prescribing it, and particularly VEGF inhibitors, very prothrombotic. Yeah. So the education of the acute cardiology team to remember cancer drugs as a potential cause for ACS. And then it's an MDT discussion with the oncologist, that dependent on the context of the cancer, the context of the MI, as to how long you might interrupt. But certainly if it's a VEGF TKI, I wouldn't restart for a minimum of 2 weeks after, and one has to balance it on a case-by-case basis.
That's the point a bit, and I think if you have time to consider it, like in a non-STEMI with little troponin rise, I would say, wait, let's see what's going on with this patient, how is he or she being treated? Well, in this case with STEMI, there's not that much time, so just act.
Okay.
So the safest way is always to talk to the attending oncologist or hematologist. Yeah. He will or she will have probably the answers.
Thank you very much.
Thank you. So thank you to the speakers. I've been reminded by the audience that there is another football team in Madrid that's not Real Madrid. So to all the Atletico fans, I've obviously been working with Teresa, so I'm sensitive. So you can always think of it as Tottenham if you don't want to.
I thought you were going to starting with Barcelona, but that's
Don't say
off
this
topic
in here.
Okay, thank you very much.